Well, thank you everyone for joining us today. We're excited to be part of the IHEMA annual conference. And we're going to be focused today on talking about patient duplicates. You can see from our screen, the title, Double Trouble, Don't Be Duped by Duplicates is our theme. So a little bit about our agenda. Some brief introductions and a quick overview of our program. First, I'm Greg Church. I'm the president here at Formedica. We're very excited. We deal with a lot of healthcare systems across the country, everything from integrated delivery networks, freestanding hospitals. We also do work with laboratories, imaging systems, health information exchanges, and our theme is really focused around improving data quality. After that, we're going to talk a little bit about what's going on in the industry around data quality. And we're going to make it fun today. We actually are going to do this in the game show format. And we're calling it What's My Identity? Based off of the 1950s game show called What's My Line? We have 3 identity management scenarios that we're going to focus on, and we've got 3 very esteemed patients that are going to be asking questions about their identity. And then we're going to talk a little bit about the Formedica MPI as a service approach to helping hospitals and health systems across the country manage their data quality requirements. And then we'll wrap up with a quick summary and next steps. Real quick about Formedica. We're in our 23rd year of being in business, founded in 1998. We today in our repository have over 100 million patient identities that we help maintain the best data quality for. We represent medical practices, over 16,000 that are connected to our platform. That's over 40,000 unique physicians. And in our data flow through our exchange network, we process both clinical transactions as well as non-clinical. That's the identity management of attributes. And that's millions of transactions that go through our platform each month. And again, we break that down based on working with hospitals, laboratories, imaging centers, health information exchanges, health information networks, and health plans. We're very excited, for this audience, because we take data quality with a lot of, respect and seriousness. We are HITRUST certified. So let's talk a little bit about the landscape today in America. U.S. healthcare is a big spend. As of 2020, it's about a $4 trillion spend, or 17% of the U.S. GDP. If you break that down further, that's around $12,000 spent annually per person on healthcare. So it's a big spend. We've got an aging population, so we do expect even higher expenditure. But here comes the problem with this. As much as we're advancing healthcare from the treatment perspective, and we have some great new technologies out there advancing healthcare from the care perspective, we still have a problem, though, with our health system from an IT perspective. We're still very disconnected. Things that now legislation is forcing us to do differently, we cannot data block. We have to exchange and share information across the health system to another health system, from a payer to another payer. But that becomes challenging, right? We've got these outdated legacy platforms that are still in production. They really were not designed for real-time interoperability. We've got poor data exchange standards that we're still advancing. And with all that combined, we still have poor data quality. And you would think that this would have been figured out, 2 decades ago, but it hasn't. And unfortunately, along with the poor data quality comes poor identity management. We don't have a way today to match off of a single unique ID that everyone has access to. There is not the magic identification in healthcare. And with that, not having a way to identify correctly, we still have problems even just normalizing tests coming in from labs and procedures and diagnoses and symptoms. So that combination still is not the right winning combination. So what do we have to do to get that thumbs up, right? To get that problem behind us? We need to focus. We need everyone's attention on health data quality. And we're going to do that through digital transformation and through interoperable data. And if we can focus on that and get everyone to agree that this is the starting point for better health outcomes, then we can actually help individual healthcare organizations expand their access to services and deliver a more effective patient and clinical experience. And this comes from the 2021 Deloitte Global Healthcare Report. Okay, double trouble. Back to our session name. We're going to break it down: patient safety and financial loss. So let's follow the pie chart. Today, believe it or not, still today in America, with all the advancements in health IT and technology and electronic health records, we still today, on average, have a duplication rate across all healthcare organizations between 10 to 20%. Following it around, believe it or not, wrong patient events that result in death or harm each year is still around 9%. And today, for healthcare providers, we're still creating duplicate patient records, even at the care team level, around 8%. So if you look at it from a hospital, health system perspective, patient misidentification costs an average hospital approximately $1.5 million each year in denied claims. Breaking it down further, that's 33% of total denials. And across the healthcare system, that's more than $6 billion annually. So patient matching, data quality, it's all monumental. It's a huge role in healthcare, but it's a role that makes an organization successful if we get it right. If we don't, incorrect patient identification leads to much more severe consequences. So we talked a little bit on the prior slide about what it means at the hospital level from a denial perspective. So think about it a little bit more. Hospitals lose approximately $17.4 million per year in denied insurance claims. And that's all directly attributed to patient misidentification, okay? So duplicate records cost a health system over $1,950 for each inpatient stay. Okay, so again, the last statistic that I had on the prior slide, again, hospitals on average, $1.5 million, this is based on 2017 data, $6 billion annually for the healthcare system as a whole due to patient misidentification. So then we'll talk about a little bit on these preventable medical errors. Okay, so over 400,000 hospital patients experience some type of preventable harm each year. Think about that. Almost 500,000 hospital patients experience some type of preventable harm each year. And medical errors in hospitals and clinics result in approximately 100,000 people dying each year. So let's take it on to the next slide. So medical record errors caused by duplicate medical records and overlays. This is a key issue facing the US healthcare system today. Again, we have hundreds of different medical record systems, both on the inpatient and ambulatory side. We've got, ancillary systems in the laboratory running for the LIS and radiology. So if you look at this combination, in your emergency room running different systems, anytime we have duplicate medical records and overlays happening, here's what it leads to. The biggest one, patient safety issues. We know it's problematic. We know patients die annually because of this. We know it puts care team providers at risk as they're treating patients. If we have an overlay, and we have two records being combined into one record, a patient comes into the ER unconscious, they cannot confirm the medications they're on and the treatments they've been in or the conditions they have, it's going to be a bad outcome for that patient. And again, patient misidentification happens all the time. You've got these various disparate systems out there where patients get miskeyed, their information goes in wrong at the registration level. And then that is problematic downstream. It impacts every department at that point. You don't get it right on the front end, it usually is a problem on the back end. And for our folks here today representing revenue cycle management, billing and coding errors are hugely problematic. You don't get the demographics right, you don't get the insurance information right, you don't code correctly on the services being provided, you're not going to be able to bill and collect on services rendered without an issue. And then, of course, reduced healthcare outcomes becomes a problem, right? If you're trying to improve the outcome of the patient's experience with better treatment and to keep them from coming back into the hospital for a readmission, those elements become problematic in doing so. And we don't want revenue cycle management to be dealing with the back end problems when we could have actually collected better information on the front end to help them ensure accuracy of the identity, accuracy of the insurance, accuracy of the coding, medical information related to the claim that's being billed and collected. Next slide. So let's talk a little bit about what happens when you look at the data and get into it and get underneath the hood with it. So we've actually taken a sample of hospital data from patient records with bad data. And in this scenario, we've actually looked at a data set of 2 million records. Believe it or not, in this data set of 2 million records, we found the following problems. No first name present. There were over 500,000 records, 513,000 records where there was no first name present in the demographics. We then looked at social security number, right? We talked about in the prior slides, how we are disconnected. We don't have, a universal patient ID. So a lot of health systems early on started using the social security number as that identifier, but that's problematic. We don't have a viable, reliable SSN on every patient. And in this particular hospital, we identified that out of the 2 million records that we actually looked at, 1,457,927 identities did not have a social security number present. It's not reliable. And if there was a social security number in the records that we looked at, it had erroneous values. There were over 238,888 identities where they had single digits applied in the social security number field, all nines, all ones. So then you cannot apply a score in the patient matching process. That's not a reliable attribute that the hospital or health system can use in the process. And we learned that, and we were able to address that with the client. Also, the physical address, no address present. Imagine 57,000 records, no address at all. So, and some of them, a lot of them actually had bad addresses. And so there are things that we had to do to normalize the data and to actually verify and go out and look for the correct address. And no phone number present, over 685,000 records. And there were an additional 1.2 million with invalid phone numbers. For example, with all zeros, all nines, all ones. And lastly, one of the things that we uncovered, many of the records of the 2 million actually had shared phone numbers, which becomes hugely problematic when you're trying to do patient matching. You cannot put a valid score or weight on the phone number if you've got thousands and thousands of records with shared phone numbers. Okay, moving along. So we want to make this fun. We want to put a little bit of humor into this, but it is a serious topic. But we're going to actually go into our game show now. We're going to have basically some rules that we're going to follow in our game show. We're going to have 3 patients that are asking very specific questions, okay, about their identity. And we're going to, kind of focus in as who's the real Kim George. And you can notice Kim George can be transposed very easily. We're also going to look at who's the real Leslie Thomas and who's the real Sandy Gray. And we look at these names and realize these are real life scenarios where the first person's name could be Greg, could be the last name in this case with Sandy. And then we're going to have the scenarios broken down in 3 ways. We're going to look at first patient data with overlays. That's going to be one of our scenarios. And we're going to have questions specifically around that to see who actually figures this out. We're going to have the second scenario, which is high patient duplication rate. And our third and final scenario will be incomplete demographic data, where we're going to need referential matching and enriched data to help us narrow in and make sure we have the exact match on the unique record. So without further ado, I would like to introduce Mr. Brian Weichel, our moderator.
Well, thank you, Greg. Excited to be here today on What's My Identity? And again, as we said earlier, it's based on the game show What's My Line back from the 1950s. All game show participants are health data quality management advisors here at Formedica. One patient, one record. So as Greg said, we're going to break this down into three scenarios. First scenario is, and I'll hold up my card so the studio audience can see exactly what I'm going to ask. It is potential overlay in a hospital electronic health record system. So let's bring on our panelists for the first scenario. Panelist number one.
Do I have two commingled patient demographics showing up in my medical record from the same data source?
Well, you know, that's probable and probably need to have further review. So let's go to panelist number two.
Do I have matching demographics of another medical record number, including first name, date of birth, phone number, mailing address, but maybe a mismatched or missing last name?
Oh, you're a patient nightmare in the hospital setting, panelist number two. I feel sorry for you. Let's go to panelist number three.
Do I have Kim and George listed in my first name field and no entry in my last name field?
Well, panelist number three, this is probably why you have no Christmas cards during the Christmas season. Can't figure out who you are. So thank you, panelist three, for that answer. But I think the studio audience has some more information they would ask panelist number one.
Has my MRN been potentially merged with another medical record to create an overlay?
Well, panelist number one, that is the correct answer. Now, with that, let's go back to Greg Church, president of Formedica, for a breakdown on that scenario.
Thank you, Brian, and thank you, panelists. Very smart question. So again, overlay in the hospital electronic health record system, the biggest risk that we can provide both to patient and to hospital facility. So again, just to define carefully what is an overlay occurs when one patient's record is overwritten with data from a second patient's record, creating a combined inaccurate record. Okay, that's really what happens during the overlay situation. So again, why is it critical for a hospital? Well, here's why. Let's break these down. Patient safety, the biggest, right? It's compromised. Wrongful death situations occur throughout the year, happens frequently. And it can depend on a misdiagnosed condition, improper treatment, or a performed procedure that was not appropriate for one of the patients. And notably, okay, this puts the hospital at risk for a potential litigation case, opens it up for negative publicity. It ultimately impacts the integrity of the overall health system and its medical providers. For the financial folks that are listening in today, the impact of an overlay can be twofold. First, the cost to correct the overlay in the HIM department, in the electronic health record system, to get in there and correct it can take up to 500 hours per overlay and cost thousands of dollars to resolve each one. It's time, it's money, it's a big process. Revenue cycle management is definitely negatively impacted and can cost the hospital millions of dollars per year in lost revenue. Denials and write-offs are the two key areas where overlays have the most negative impact. Brian, back to you.
Well, Greg, thank you for that. That's great insight on a potential overlay in scenario number one. So let's go to scenario number two before we bring back our panelists. We're looking for legacy EMPI with a 20% duplication rate. So let's bring back our expert panelists and let's ask them some questions. Panelist number two.
Does my identity perhaps exist multiple times in the hospital registration system?
Probably more so than you think, panelist number two. It's highly probable. And again, we're going to have further review on that. Let's go to panelist number three.
Do I have more than one patient record with the same last name, first name, date of birth, phone number, but a different mailing address?
Well, absolutely. That does happen highly, and it's probable. And again, it's part of the overall situation that we see on a daily basis. Let's go to panelist number one.
Do I have Leslie listed in one medical record as my first name and Thomas listed as my last name in a second record with all the other matching attributes in both records?
You probably do, more so than you think. And again, that's going to have further review. But what does the studio audience think? I think the studio audience is looking at panelist number two.
Okay, is my identity associated with multiple records in the EHR?
Panelist number two, that is the correct answer. Thank you very much. Now let's go back to Greg Church for a breakdown on scenario number two, the legacy EMPI with a 20% duplication rate. Greg, take it away.
Yeah, so let's break this down a little bit. And when we talk about legacy, so if you remember, patient matching is not a new topic. I mean, patient matching requirements have been out there for decades, but most of that was done outside of the HIS platform or outside of the electronic health record system. And so many of the systems in the early days were really designed on legacy technology, a relational database, where you had to load data, you would have to score, you would have to adjust, you'd have to go online, you'd have to readjust. All of that would delay the whole patient matching process. You fast forward today where you've got many, many systems that are running inside of a health system. Of course, many people are consolidating those systems, but if you look at what's out there today, there may be multiple medical record systems. When you acquire outside facilities, you got medical practices that have different systems. You bring that all together, and if you have an MPI engine that was never designed for that type of real-time interoperability supporting, potentially hundreds of data sets, you're going to have this problem with high duplication rate. So again, looking at from the hospital administration side, and this duplicated medical record scenario we just played out for the game show, it appears there is a legacy MPI engine, which is now unfortunately not being able to pick up that extremely high duplication rate. And in this case, identity and record duplication continues to go up because you don't have enough time to actually resolve it. You can't go offline as new data is coming in. So that data is compounding with a higher duplication rate. Even if you throw more bodies at it through HIM and you put more resources on it, you're probably just going to be managing the problem, right? When a new medical record is being created or an overlay is being created, but those legacy duplication issues are still out there. That's problematic if you're trying to create a longitudinal medical record for each patient across the health system and sharing that information from facility 1 to facility 2. And you really don't want to actually share that information outwardly to the patients yet because they may not be actually capturing their current view of their information. So oftentimes, duplicate medical records are partial duplicates, meaning they're only capturing a portion of the patient's medical history. If you have medical record system A with a lot of the clinical notes and the encounter information, but you have another system that's maybe capturing more of the latest laboratory values or imaging and meds, now you're actually putting both patient and provider in a risk situation where nurse comes in, says, oh, some of the patient's information is over here. I'm going to validate the vitals. I'm going to do things as the nurse, but I'm going to slap a blue color wristband on one arm. Provider comes in, looks up the other portion of the record in the second system and slaps a different color wristband on the other wrist. Now we laugh at that and think that doesn't happen, but that really does still happen, today across America. So again, creates a patient safety risk, both for patient and the healthcare provider. And all this can be easily prevented if you have the right MPI engine and data management review process in place. So Brian, back to you.
Yeah, and I think that's great. Real world use case scenarios, Greg. Thanks for presenting that with us. Scenario number 3, and as I hold up my card again, incomplete patient demographic record in need of enriched data from a reliable referential matching source. So let's bring back our expert panelists to answer some questions for us. Panelist number 3, are you ready with your answer?
Yes. Do I have a phone number missing from my demographic record?
You're asking me? I don't know. Let's ask the audience. No, that's probable and probably would need further review. Panelist number 2.
Do I have only one mailing address listed, even though I've lived in 4 different places over the last couple of years?
Yeah, and that's why Uber Eats can't find you and your tacos are cold. Sorry about that. But it is a probable, and it is the overall situation that we are dealing with. Let's go to panelist number 1. What do you say?
I say, do I have Sandy listed as my first name and Greg as my last name? And maybe another record where the first and last name are reversed?
Surely you jest, but there again, I will not call you Shirley. It's probable, and it's also needs further review. But I think our studio audience wants to hear more from panelist number 3.
Is my demographic record missing key attributes to accurately match me as a unique ID in the hospital information system?
Winner, winning chicken dinner. You got it, panelist number 3. Very good answer.
Yay.
Now with that, let's break down scenario number 3, going back to Greg Church. Greg, take it away.
Thank you, Brian. And thank you again, panelists, for those great questions. So again, as we are looking at how do we advance patient matching, right? And how do we look at improving overall data quality? The engine itself is pretty important, but there are things now that we can do to look at how do we match against other sophisticated data sets. And referential matching is that process that allows us to take what looks to be a duplicate, but we're not able to make the exact judgment call on that through the scoring and the technology itself. So we'll take those 2 records and we'll find a data source that we have access to, and we'll run it past the data source and say, let's verify, is this really Brian Weichel? Is this really Gregory Church? Is this really the exact person that we think it is on those 2 records? And if it is, we'll get a yes, no match. And if it's yes, the thing that we do that makes it different and more valuable to that identity for both identities is looking at what did we actually match on? What was incrementally different, or what did we uncover about that record? And that's where we call it data enrichment. We can actually bring in a value that may be missing. Remember, we talked about the hospital scenario where we looked at those 2 million records where first name was not actually entered as a field attribute. If we can match on last name, we can match on date of birth and a phone number and an address, and we know it is Brian Weichel, but BW or B Weichel was actually in the record, and now we know that Brian is the first name, we can now bring that into the record, enrich it, so we always now know it's Brian Weichel in the identity. So it's important when you're looking at patient demographic records, where we've actually got 2 patients' demographic records that need referential matching, And we know we can enrich the data from these really enriched data sources out there, which will help us not only get the best match and create two unique records, but the benefit is making sure that we can curate missing data attributes that are uniquely needed to continue to keep those records at the highest level of quality. And you can do that to improve communication. We look at the COVID use case where a lot of hospitals got into COVID testing through their laboratories. In many cases, those requests would come in with low quality attributes, which becomes problematic when you go in to result out on the patient's test result. The more you can match, the more information you can have in the attributes, the more viable information just makes that unique record much better, a stronger use case for identity matching. So let's spend a little bit of time here. Important, as you're learning and maybe thinking about how to further enrich and improve your data quality, data management processes. So a lot of times we talk about technology, we talk about software, and software is great. Don't get me wrong. We're a software company. We have a very good MPI engine that does a lot of different things. We can do scoring in real time. We can bring in hundreds of data sets. There's no restrictions. We can bring in a lot of different attributes on our identities. But what happens, it becomes a resource issue to still have people dedicated at the hospital and HIM to really spend the quality time to look at these identities, especially if you've got a duplication issue today that you're trying to work down. So we've created a program, we call it Formedica MPI as a service, where we take it in steps. We take it from, let's assess first, what are the problems for an assessment process. We look at things that we were breaking down in that 2 million set that I referenced earlier in the presentation. What's going on at the record level, where we have good attributes, where we have missing attributes. And we do this step first because that's kind of the baseline. Find out what we don't know. Once we know that, we can then actually start bringing in the data to the engine, which is the software, start scoring it much more methodically, putting better weights on certain field attributes, which actually will strengthen and improve the match rate. And when we do that, we typically can take somebody, if they're at a 15% duplication rate, and lower that just through that review and scoring process, down by 5-8%. Then when we talk about referential matching and data enrichment, that's another step that we can apply, which again, leverages the system, the technology, and helps bring down those matches into a lower duplication rate. Now, people ask about technology, it's advancing. What else can we do out there that actually can improve upon match rate? We have applied what we call machine learning prediction. So as our data stewardship team in our process where we apply people and they're looking at these potential matches on the work list, as they're actually resolving those duplicates, the system through machine learning prediction is actually saying, okay, now I understand what made this identity an exact match. And it'll actually validate if it would have done the same thing to actually systematically merge that record. And as it's learning that process and that routine, we're now relying less on the human eye to be in there and working the record, managing more off of the system scoring and machine learning prediction. So if you look at this whole process, right, if you look at scoring, machine learning, you look at referential matching, data enrichment, this is how we can actually, with our customers, get them from a double-digit duplication rate down to a single duplication rate of 1% or less. And we've done this so much that we can actually guarantee this process through what we call our MPI as a service. So again, we're a platform for data quality where it incorporates both the technology, machine learning, sophisticated scoring, our rules engine. We have data scientists that have come out of hospital registration. They know how to work the data. They know why it's important to have certain attributes and make sure you don't use single letters or single digits. So they're always looking at it from that perspective. And you combine this into a 4-layer process. That's how we actually can help people get to that 1% or less. And we do that with a lot of confidence. We help solve and maintain patient matching requirements in different data sets across the country. And going on to the last slide. So again, just kind of summarize for everyone here. People say, well, shouldn't I license my own MPI, or can I not rely on my MPI that's part of my Epic or my Cerner or my Meditech system? So yes, there are matching, patient matching algorithms built into a lot of the technologies that are out there today. But again, they were not really designed to do it at scale, to do it, you know, when you're dealing with so much volume of data coming in from the outside and from various, you know, departments. So our mission, as we talked about, and you've seen it in our tagline, is to really focus on how do you get to that single unique record that's longitudinal, made available to everyone, and create a single patient record. So I'm going to break it down just to recap, you know, from a learning perspective. When you're talking about improving patient matching and data quality, if you're looking at bringing in a partner from the outside, ask them if they do a data quality assessment. Find out if they're willing to take your data and take it up front and actually break it down and look for those data quality problems. Look for things like missing patient demographics, registration errors. Look to make sure you can actually validate that actual duplication rate so you know what your baseline and starting point is. If they do, then you're going to be much better positioned to actually use MPI technology that's out there available today, and make sure that the vendor partner you're talking to, whether it's an existing partner that you're already using or somebody that you're vetting for a new partner, make sure all this can be done real time. Make sure you can make on the fly scoring adjustments. Make sure that you can define some of your own rules based on some of your own patient scenarios, right? From a matching perspective. Because if you can, then you're going to get the 10x match rate will go up. You're going to have higher precision. You're going to rely on better scoring on the different attributes. Make sure that you can be able to take unlimited demographics on a patient. Make sure you can have multiple values per demographic attribute. If you can, again, you're going to take what's a big problem, you're going to narrow it down into a much smaller problem. And then, of course, with machine learning, artificial intelligence, a lot of this, you know, prediction technology that's becoming much more standard, you know, across healthcare, that allows you, again, to improve systematic merges, right? Relying on the technology as the way that our humans have been doing things, but not necessarily having to throw more resources at it. Leverage the technology, leverage what the system should be doing for you. That'll reduce the number of people from a review perspective. And then, of course, what we hear a lot about today and read about is referential matching. Great stepping stone, great process to add, you know, to your data management protocols. But make sure when you're speaking to a current vendor partner or a new vendor partner, make sure it doesn't just stop at referential matching. Make sure that they can actually help you curate the data and bring in more improved attributes, right? Again, just to validate, it helps you extract and look at exact matches versus potential matches. It'll give you a good score weight on doing that. And then it allows you to bring in those missing data attributes on each uniquely matched identity. Now, if you do this and you really have a commitment from your data management team inside, and you have the technology and the people in the process, you should be able to, with a lot of conviction in your own process, be able to get to that 99% database accuracy. That's all what we're trying to achieve here. And as you're starting to work and have to exchange data outside of your own health system with another health system, because Brian and Greg and our panelists may want to have their information that's aggregated into a single view so they can actually have the complete picture of their own healthcare experience. That's on the patient side. You have providers who are now seeing patients that are inside and outside of their network. To do that reliably, to share that information, whether you're connecting through your state HIE, you're participating, you know, in some other clinical trial, you don't want your patient information to be exposed if it's not accurately matched at the identity level as well as the clinical level. Okay. So with that, Brian would like to spend just a minute or so kind of talking about how to engage with us and talking about next steps. If what we found today through our game show environment, of interest to you to learn more about what we can do to help your facility.
Well, thank you, Greg. I appreciate it very much. You know what, before I go in, actually, I would like to ask you a couple quick questions. I mean, I was excited about doing the HEMA presentation. What got you excited about wanting to participate in this year's HEMA presentation?
I think, Brian, that's a great question. As we're dealing with different health systems and different provider organizations, around the country, we hear that the data is becoming of value, right? Some people say, data is becoming the gold in healthcare. And we want to do more around predictive medicine or precision medicine. We want to make sure we're creating the best health outcome, for the patient. And we look at data, there's so much data available, but for a provider organization, and when we're talking to the various organizations out there, what's really the most important is, that laboratory data is super important. It's what really populates the medical record. It's what, physicians and healthcare providers make their decisions on, right? So that data, is sitting out there and it's done well from a, diagnostic perspective, but for some reason, it's not getting, reattached or connected to the right individual. It's not a reliable source. It just becomes more data that's compiling out there, but it's not actually helping to improve the overall patient experience and to ensure that we have the most accurate way to diagnose and treat the patients. So we're excited when we talk about health data quality and we look at hospitals and health systems that are growing, they're acquiring, they're merging, and now they're having to collaborate, outside of their own, ecosystem. We really want, to go on a campaign, with each hospital, with each health system, and then really take, in the process of being a great data management partner for them. And we always like to ask questions too, and it's something I would challenge the audience about a little bit. Maybe they can follow up with Brian on this. Do you know today what your duplication rate is? Do you know today what are those data quality issues that are inside of your demographics? Are you comfortable that you're matching the demographics every time to the right clinical record if you do have two different systems that are in place? Are you comfortable that the lab values and the imaging values, and you're looking at the medication data, all that's coming together as a single unified longitudinal record? And we say this with a lot of sincerity. If you can't answer that question without any doubt at all, and if you don't believe that your record duplication or your identity duplication is as close to 1%, and if you think about it, that's 99% accuracy, that's still leaving 1% that you'll never really are going to be able to resolve because there's just so many things outside of your control. You might not get enough demographics or information if it's coming in from an outside connected facility. But what I would challenge the HIM folks on this call to do in their teams is start from the beginning. Start from where information is collected at registration. Think about the data quality standards you want to have in place. Raise the bar a little bit higher. Make it required to do certain things. Don't build rules where if you don't know something, put a single digit in or leave it blank, because what's going to happen, that's going to be a downstream problem that somebody else outside of registration is going to have to figure out on their own. Get it right on the front end, makes it easier on the back end. Then you can take the modern day technologies through MPI. You can take the modern day AI, machine learning prediction. You can take referential matching and data enrichment to the next level, because now you're looking at a smaller use case that allows you then to say, I can improve my data quality and my match rate much more efficiently, cost effectively, if I do it, but I start at the beginning at registration, get everyone trained, have a really good data quality program in place, and then people on the IT and the HIM side can reliably say, we've done our best on the front end. Now we're going to leverage our technology. We're going to leverage our people and our processes. We're going to maybe bring in a partner like a Formedica or somebody else that does this with a lot of precision and make sure that we can always maintain the best data quality as close to 99% accuracy. So I'm going to leave you with that to think about what you currently do. Love to talk to you. Brian, quick mention of how they can get a hold of you.
Yeah, absolutely. And I'm glad I did a follow-up and asked you that question because, again, clearly we're passionate about this issue. So what I'd like to leave you folks with the HEMA that are tuning in to understand a little bit more about what we're doing today. Here's the thing you may not know. Notice the 317 area code for all the IHEMA folks here in the state of Indiana. I'm a local guy. I'm right here. I'm in Fishers, willing to come see and answer any questions personally, or if you prefer Zoom or Teams. So again, I'm right here down the street from you, from probably most of you, and would love to help and address any additional questions that you all might have based on our presentation today. So just a quick encapsulating, we talked about potential overlays. We talked about incomplete patient demographic records, needs and data enrichment, and also legacy EMPI. So again, I'm Brian Weichel, your host with Formedica. Thank you, Greg Church, and thank you for all our panelists today that helped bring apart this presentation for IHEMA's April conference. Have a great day, everybody. Take care.